Hi, everyone. Can I have your attention? Thank you. It is my pleasure to introduce today's speaker, Amy Wesolowski, who is an associate professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. She obtained her PhD in engineering and public policy at Carnegie Mellon University and was a postdoctoral fellow here and at Princeton. Her research focuses on understanding human behavior and how it relates to infectious disease transmission, and she works on multiple pathogens, including malaria, measles, and HCV. Welcome back, and we're looking forward to your talk very much. Thank you.
Thanks so much. Thanks so much.
Someone is saying comments.
Sorry?
I think the mic is muted. People are saying on the Zoom. Sorry about that.
Yeah, this is muted. Can folks on Zoom hear now? Yeah, okay. Thank
Great.
you. Sorry.
Nope, you're good. By the next pandemic, we're going to be really good at Zoom. Thanks so much for having me. It's weird and a little uncanny valley to be back. I think I haven't been back for like 10 years or so, but it's very nice to get to see everyone. And also, for anyone in the audience who wanted to hear about malaria, I'm very sorry. This talk is not about malaria, even though that does remain my favorite pathogen and a better pathogen than any of the others. I obviously did my degree with Caroline, and so, so today I'm going to talk about some of our different kinds of projects that we have going on that are trying to look at sort of how can we better model human behavior. And so the first part's going to talk about some population-level mobility projects that we've been working on, and then the second part is going to talk about looking at the injecting behaviors of people who inject drugs. So why do we care about this? So there are many different ways that sort of human behaviors might impact infectious disease transmission. Some of those things might increase the risk of a disease. So this is an example where you might have people who are traveling between locations with different transmission settings when able to reintroduce the pathogen, or maybe they're susceptible and they're going to get infected where transmission's higher. You can also have other things that will increase the risk of infection, where some people might have many more contacts. So here, this individual who's circled in red has many more contacts than the individual that's circled in blue, and so that person in red might be at a higher risk of getting infected. You can also have things that will reduce the risk of infection. Some things like interventions like bed nets for malaria, that if you sleep under those, it might reduce your risk of infection. And other things like vaccines, where getting a vaccine, or ideally getting many vaccines, could greatly reduce your risk of an infection. And historically, when we think about different kinds of models and ways we can incorporate these behaviors, we often use a very simplified approach, like the basic SIR model, where we assume that people mix uniformly, also called mass action, and we're not really incorporating a lot of those heterogeneities that might exist in our population that might be impacting disease transmission. And here, the assumption is, everyone is a thing in a box, and then they're just kind of bouncing around at one another. So it doesn't really matter that maybe some people would have more contacts, maybe some individuals are more likely to uptake an intervention. But we know that data is one way that we're really able to try to tease apart some of these things and better understand. Is there an issue with the Zoom?
Yeah, they're not able to see the slides.
Oh, okay.
Sorry. Can people see the slides now?
I could actually see the slides.
Oh. Can you see them now? Still? Okay.
We can help that person who couldn't see the slides with their computer later. So we can use some things like data. What? Bill has advice. So if you would like to email bill.hanage at yahoo.co.uk, he is available to help you with your Zoom assistance. Yeah. So data can help us figure out what is actually happening. And so this is examples. of sort of like the polymod kinds of style data where we know that like not everyone might have contacts with other individuals and there might be a skew with age. But also all data is not necessarily created equal. So this is work that was done that was looking at trying to estimate vaccination coverage using a bunch of different kinds of data sets. And what they were able to see is some of the data, like the Facebook data that might have particular biases, was greatly overestimating it compared to other things like the CDC benchmark when that existed, and also some kinds of polling firms where you might be explicitly trying to target different individuals in the population. And so one way we can deal with like a lot of crappy data is we can try to use different kinds of models to fit those data to get sort of general patterns that we're trying to observe that we might be able to explicitly account for some of those biases or errors. And so today I'm going to talk about two different scopes of work that we've been working on. So the first is trying to look at population level mobility. And in that, we're really interested in trying to figure out how we can make more realistic models of human travel. And then the second part, I'm going to talk about behaviors of people who inject drugs and talk a little bit about one of the projects we've been working on about how we can incorporate realistic injecting behaviors into HIV and hepatitis C transmission models. So to start with the mobility. So we know that mobility is important for infectious disease spread. In particular, infected individuals are able to introduce pathogens into susceptible populations. So this is a paper by Rachel Baker that was just looking at sort of like the global spread of different infectious diseases. And you can see, you know, on the bottom there, you have the SARS-CoV-1 pandemic, you know, lots of things driven by colonialization and things like that, where you can have these sort of global spreads. And also we're often interested in this on like finer timescales too. So during the COVID-19 pandemic, there were lots of questions about how can we use mobility data to better understand sort of transmission patterns. So at the beginning, you might be interested in trying to figure out what's the risk that something will be introduced and where those source locations might be. As you implement things like stay-at-home orders or other travel restrictions, you might be interested to try to see what was the impact. Has travel really decreased? As you lift those, you might be interested in trying to better understand and quantify, has travel resumed? And then later on, as maybe you don't have as much transmission, you might be interested in trying to figure out what's the risk of it being reintroduced. So I'm going to start with sort of a systematic review that folks here also helped us out on, that was led by Katie and Natalia, where we analyzed population-level mobility data to understand SARS-CoV-2 transmission. And this slide has way too much text on it, but if anyone wants these data, it's like very painful to do this systematic review. So if you have anything that you might want curated list of papers for a systematic review, these are the different data we collected. But in particular, we were interested in trying to figure out sort of like what data people are using, how are they using those data, and what are they able to say about disease SARS-CoV-2 transmission by using those data. So these are the different kinds of data we extracted from all the papers. We reviewed about 5,000 abstracts this is just from the first year of the pandemic. In total, there was 232 papers that were included for the full review. And we really focused only on papers that there was quantitative data about populations, which we determined was 1,000 people or more, and that was really just focused on transmission of SARS-CoV-2. So for example, there are some papers that would be like a one-case report, or other papers that could come in this mesh term that's about mobility, that could be about like people having like skeletal mobility problems after having COVID-19. So what we actually found was that like lots of people were using lots of different kinds of data with effectively no temporal trends. We categorized data sets to be like sort of internet-based data like Apple or Facebook or Google data, Baidu data, mobile phone data, flight data, and really there were no temporal trends in sort of what kinds of data sets people were using. We also analyzed and looked at sort of, given these many different kinds of data sets and different things you can calculate, were there any trends in that? And there weren't necessarily, right? There's lots of different ways we can define mobility from these different data sets. We can use it by saying, like, what are the trip counts, or how much time are people spending at different locations? But really, it's a pretty nice hodgepodge of data sets. There are some trends, but overall, people are kind of like taking whatever they got. They had a lot of different things, and they calculated a lot of different things from them. But one thing that we did notice about this was that effectively no one was modeling mobility. So there were only 6 instances out of all of these papers where they actually modeled mobility. And also no one was really evaluating, did I even need mobility data? So 80% of papers did not even test if they actually needed the mobility data in their analysis. And so we have had a long interest in trying to better understand mobility and also thinking about ways to model it. This sort of spurred a number of new projects that we were kind of focused on given the lack of sign of modeling mobility. This may be increasingly important as data sets go offline too. So one of the most commonly used data sets was the Google mobility reports, but as of 2022, that data set is no longer being updated, although the historic data remains publicly available. So if pretty much all the analyses did not model mobility, they just used the data straight or did like a basic statistical model of it, if that data is no longer accessible, what are we going to do in sort of future outbreaks or pandemics? And a lot of this work about thinking about models just come from the very basic gravity model, which has been used many, many times. And effectively what the gravity model says is like people are going to travel to more populated places as long as they're not too far away. And so I'm going to talk about 3 different projects where we're kind of building on this gravity type of model. Where the first one is talking about sort of individual variability in travel. The second is going to be about how we can fit these models with different data sets. And then also about an R package that we're putting together to try to help with modeled estimates. So the first project, so this is all being led by Noah Parker, who's a researcher in my group. And the basic question is, we often assume that all individuals in a population have an equal chance of traveling. And so in this instance, we often evenly divided. If we have 5 trips from a location, we'll say everyone has a 1/5 probability of traveling, instead of saying there might be one person who travels 5 times. And this could be really important if you think about like who's actually infected. So, if you have that everyone has an equal chance, you have one person infected, yeah, that might get introduced into a new population. But if you have this skew that one person is actually the only one traveling and isn't the one infected, that's going to be really different than if they are the one that is infected. And so we've been using individual level mobile phone data from Zambia to try to develop a model of trying to better understand what's that individual, how are those trips distributed amongst individuals. And so the way this process is working is like we're fitting a model where we're first predicting sort of what proportion of your population is going to be traveling or not going to be traveling. And then given that value, then how are the trips distributed amongst all of those individuals who are traveling? And so Noah's been able to fit this model, and we've been able to, so on the right-hand side are some of the predictions from the model when we're looking at like individual trips between different populations, and we can do a much better job of sort of predicting both how many people are traveling and the distribution of those individuals who are traveling. The next project that I'm going to talk about is about fitting models with multiple types of data sets. And this is all work that was led by Natalia, who used to be a PhD student and postdoc with me. And so one of the things that happened during COVID-19 is there was a lot of data that became available. So, like everything on the internet was somehow collecting mobility data. A lot of companies that maybe you would have to pay for their data, suddenly you didn't have to pay for their data. And there was also routine data like a census that was already being collected. And so there's lots and lots of different ways you can measure mobility, and all those different ways might also cover different types of administrative units, might have different temporal scales, might cover different parts of the population. But there are actually very few models where it's explicitly trying to model one estimate of mobility given a bunch of different data sources. And so Natalia, as part of her thesis, worked on, in Zambia, we had data that came from multiple different sources. So we had like the Google data and Facebook data. We had some survey data and mobile phone data, and the DHS data to try to build a model where it is explicitly trying to leverage the fact that you have multiple different data sets over the same geographic area. And so this is just building off like that standard gravity model where you're trying to estimate the amounts of trips between populations. But the difference is that we're just making it sort of like in a basic Bayesian framework where your prior might be informed by another data set. So if I'm trying to fit my model to mobile phone data, I can first fit and use a prior of some of those parameters based off of the travel survey data. And so for all these different data sets, we compared sort of like how good is it if I try to inform some of my parameters based on one of the other data sets that I have. So we combined all the different data sets together. They all varied quite differently. So the first thing to just look at like the probability of departure. So who's on that diagonal and who's not on that diagonal? What's the probability of traveling? We have like the DHS data, which are the demographic health surveys, RIP, Facebook data, mobile phone data, and travel. It's the end of our public. We might as well enjoy our time while we are here together. Facebook data, that's looking at like mobility of people who have the Facebook app on their phone going between places. Mobile phone data, which is based off of the billing records, and a travel survey that we run. And so if you just look at the distributions for like who's actually traveling, you would actually get really different estimates from if you used each of those different data sets, particularly if you just use them by themselves. So then when we fit that data, what we really found was that effectively if you use the mobile phone data, which had the largest geographic coverage and the largest number of individuals represented in that data set, it really would kind of like swamp your likelihood for any of the other data sets. So this is an example of the coefficient that goes on distance, and the ones in blue are when you don't have there is no prior, and then the ones in red are when you use mobile phone data as your prior. And effectively, as soon as you use the mobile phone data, it like brings you down to all of those parameter estimates. When you do some simulations of them, whenever you use like the mobile phone data as your prior, you're pretty much always going to get the estimated this is simulating measles that look just like if you had only used the mobile phone data. And we think part of the reason is because it has so many more people in it, but also because it has a lot better geographic coverage often, and so you're able to sort of like inform some of those travel routes at a wider area of the country. The last thing that I'm briefly going to mention is our package that we're putting together. And so during the pandemic, we released one R package to just fit mobility models, but that still implies that you have data or that you can fit those models or that you know how to fit those models or not. So we've been working with Lai and Andy Tatum at Southampton using a lot of their Facebook activity space data. So it's Facebook users that get recorded the location, and then they're looking at when they go between different tiles across different countries, across sub-Saharan Africa. And so these are all the different countries where there is those data available. And this is all led by Jasmine, who is a researcher who's going to be starting her PhD soon at Princeton. And so we've been analyzing these data for all those different countries and looking at sort of what are the coverage levels, how can we fit a suite of different models to them, and sort of make an R package ultimately with the predictions from this. So these are some of the tile level, admin 2 level, and admin 2 level data that we predict from the gravity model, from the data in Zambia. And we're also putting together like that you could fit a whole suite of different models. So that way, if you have a favorite mobility model of interest, you could use those estimates, but also trying to give you a sense of how far are they from the actual data, the actual raw data. And then seeing sort of like what is going to be the impact on what your estimates might be when you use these different kinds of models in different settings on different admin units. So those are all the things that I had to talk about mobility, but because my talk has like almost no flow between the two, are there any questions about the mobility part? Yes?
Have you looked, so something that we've seen in some of the survey data is that just the crew, like, do you travel or not, is really culturally specific.
Yep.
And within a demographic specific, like women and men or whatever. Have you looked internationally at just that ratio and how much it varies and whether there's like data just on that, like are different demographic groups moving or, some cultures are more or less likely?
Yeah, so we have looked at it a little bit. So we've been running a study that's Gates funded in Southern Africa that is looking at like mobility patterns across like 5 different countries in Southern Africa. And so we have been looking at some of the data from that. Because there were travel surveys included. We don't necessarily find as much of a gender difference, although you do see that men often travel internationally more, but we see much more of an age difference where younger individuals are not traveling as far as other ones. But we haven't done like a whole global systematic. In in some surveys that we're running in the US, we don't necessarily see a huge difference. It seems to not be as much driven by gender versus by economics status, so how much money your household is making from the states that we've been running those. We're running like them in Maryland, Georgia, North Carolina, and Florida, and there we see that seems to be like a better like a more important thing, but we don't necessarily see some gender difference. But I know in Bangladesh, there are huge gender differences in sort of who is traveling or not.
And then the other question I have, in the mobility package, the R package that you're doing around it, can you use your Zambia stuff to kind of put mobile phone priors onto some of the Facebook data?
Yeah, we're throwing all the data that we have into it as much as possible to fit as many models as we can to provide those. So all the different data sets that we have are using to try to make it like the biggest suite of things that we could use. Mm-hmm. Yes?
Is that difference between like app-based mobility and mobile phone, is that consistent or reproduced elsewhere? Like, is there kind of
There have been shown differences, yeah, that you get them. Not necessarily in like the parameters of the gravity model, or like not everyone fits those and stuff, but you do see consistent differences in sort of who's getting represented in each of those data sets. Where the mobile phone data, you always get like more coverage, and it's like smoother and it's like wider, kind of. Yeah.
And is the story about like selection versus they're collecting somehow different information in terms of?
I think it's more likely selection than it's that they're fundamentally collecting different information. So I think it's different when you're trying to compare like Facebook mobile phone data to like airline data. Like those are collecting, I think, like unique kinds of mobility patterns, whereby mobile phone data would be collecting like very local, regular movements and things, whereas airline data, those are like bigger trips, those are over larger distances and things. I think with the like Facebook mobile phone comparison, it is probably more about like how the data is collected and who it's getting collected from and how it's getting processed to. Great. Okay, to have no transition, so now I'm going to talk about some of the work we've been doing on modeling the behaviors of people who inject drugs. So people who inject drugs, or PWID, bear a disproportionate burden of many blood-borne viral diseases, and they're also just a very vulnerable population. So for example, it's been estimated, compared to the general population, people who inject drugs currently or have a history are much more likely to have HIV, and also mortality is very different, increasingly different too because of synthetic opioids and the fatal overdoses. And so this is a very vulnerable particular population whereby it's very relevant and useful to try to think of ways that we can improve some of our models that we develop of these populations that make them much more realistic and much more catered to the actual population. And so all of this work is embedded within the ALIVE study. So the ALIVE study is an ongoing community-based cohort in Baltimore City. It started the year I was born, and since then it has been running continuously, where they've been enrolling individuals with a history of injection drug use or current injection drug use. And so everyone is an adult. They have been completing semi-annual follow-ups since 1988 that included like a whole suite of information. So they ask individuals about their injecting partnerships, what they're injecting, what they're using, also about things like mental health and healthcare access and like general they know about people if they're diabetic. It's like a huge, gigantic behemoth of a project. In total, there's been about 5,000 to 6,000 participants as of 2023, which was the most recent enrollment, and there's about 7 visits per person, although there are some individuals who have been in the study since like almost the beginning of the study. There is one person who is like a half Asian person who's been there since like 1989. And so it's a really, really interesting, unique lens and way to sort of better understand sort of like how differences have also been occurring in this population as there have been different decades and things of different kinds of drugs that are common in Baltimore, different policing policies, different access to treatments. It's a really wealth of information to try to develop models around that. And so this is a population that has a very high incidence and prevalence of HIV and hepatitis C. And so this is just since 1988, the zero incidence per 100,000 person years that was created by Ishan. But it's a very high risk, high highly vulnerable, high HIV hepatitis C population. And so during the COVID-19 pandemic, there was a lot of concern that because of closures for different harm reduction services and limited HIV and hepatitis C transmission, that it's going to be particularly bad for vulnerable populations like PWID. There was a number of papers that came out that were sort of talking about this, about sort of like closures of things like syringe service programs or SSP that maybe closed temporarily or maybe had shifted hours, or some of them have closed permanently. Where people were not necessarily able to get harm reduction treatment services, and also were not able to access HIV testing or hepatitis C testing or care. And so this is very piecemeal of what exactly happened. So some places were able to continue services, some places were able to continue services to a more limited degree. Some places were able to stay open, but it was really irregular hours, so it was very difficult to access. But overall in the United States, there was definitely at the beginning of the pandemic a lot of concerns, and a lot of people who needed these services were not able to access them. And so there were a number of, 10 minutes. There were a number of modeling projects that were done, and almost uniformly, they sort of predicted that we would see this surge in HIV and hepatitis C because of these closures. What actually happened is still unfolding and unclear. Part of it is like HIV, it's going to take a while to really understand the effects. But there are very few instances within the United States that we saw like a huge spur or like a huge outbreak of hepatitis C or HIV. There are a few that have occurred, but overall, a lot of the places it seems to be a little bit stable. And so one question that we had was sort of, this is also work led by Jasmine, is like maybe people also started injecting differently, and they had different injecting behaviors during the pandemic. So we developed this very complicated individual-based model where we're modeling like individuals who inject drugs. They can stop using drugs for a while. They can reinitiate. They can have different injecting frequencies. They can have different service utilizations. And all of this is like informed by the data from ALIVE. And so we were really interested in trying to better understand, like, can we use any of the data from ALIVE to better understand behavior patterns and see how that might have possibly mitigated some of these closure impacts. So when we just do like a basic model of just looking at closures, yeah, obviously HIV prevalence was going to go up. That's like a homework assignment. You don't need a fancy thing to do that. But what we were doing also is like analyzing some of the data of individuals who were enrolled in ALIVE and some of their surveys during and post the pandemic, whenever you decide the post starts. So these surveys were also conducted in 2020. They were all phone-based surveys. And we were interested in seeing of like how has the COVID-19 pandemic been impacting you. So one thing we noticed when we looked at these individuals is there was a lot more people who were more likely to be stopping using. Why that happened can be a number of factors. Some people didn't have access. It was much harder to acquire drugs at the time period. Some people also switched to non-injecting drugs, which may have been a little bit easier to get then. But we had a lot of people who were moving from these early cessation to into this early cessation group. But it's a complicated story because we also saw some things like individuals post-pandemic also were more likely to be injecting more frequently. So those who remained injecting did increase their injecting frequency. But overall, a lot of the risk factors for HIV transmission and hepatitis C transmission kind of decreased. People had fewer drug use partnerships. They reported fewer individuals of their drug use network that they were injecting with, and many, many fewer individuals were sharing syringes with any of their network members. So when we actually include all of that information, so including behavioral change, so the lines that are and the area that's in red, we actually don't necessarily see an increase in HIV or hepatitis C transmission. And in many instances, it would remain stable or go down depending on how long these behavioral changes would sort of last. When we compared this to some of the ALIVE data, our estimates were like broadly similar in terms of prevalence estimates for the later years. And so what we really found was that it could be part of the reason why we might not have seen these large outbreaks of hepatitis C or HIV could be if in other parts of the US they had similar behavioral changes during the pandemic, where people were sort of injecting with fewer individuals, injecting less frequently, and also much, much less likely to share any syringes. So while service interruptions, which occurred in Baltimore City, may increase sort of the HIV burden, some of those behavioral changes were able to possibly mitigate some of those increases from service interruptions. This is all really contingent also on sort of how long you assume sort of those behavioral changes will last. Like now that we're a number of years out, we're still seeing that it is kind of different in sort of injecting behaviors and injecting practices, but it's not really clear at all sort of how long that will last and sort of what might be some of the lasting effects of that. So just as a conclusion, we've been working on a lot of different kinds of projects to think about how we can actually incorporate behavioral data to make these models hopefully more realistic. And ideally, there's ways that we can use that data to sort of validate them so that even if you don't have access to those data or those data might not be available for some other reason, you can still use some models and get a better understanding of sort of what is the uncertainty of those models and how can you still use them in your own applications. But in particular, sort of like thinking about how we can better leverage and use actual data from particular populations to see how those behaviors might be driving or not driving transmission patterns. And there's lots and lots of people and a lot of different funders who are all a part of this work. So that's all I got. Thanks.
Thank you. I think we have time for questions.
Thank you so much. It's more like a broad or general question, but like, how do you think about the trade-off of simplifying behaviors to be able to incorporate in these models versus, I guess, like trying to capture like that big complexity of like how humans interact with each other and all of this?
Yeah, I want it as simple as that you can get away with. I like a minimum adequate level of simplicity. I think I like a simple model just because it's like, you know, you like take a problem and then you break it down to like easy parts and then you just deal with those parts. Seems easier than trying to incorporate everything. I think for like some of the work for like the PWID work and stuff, we don't really know how to model some of those interactions. So we have like a huge amount of really detailed data of like people from many, many years where we know exactly like where they lived, what they said they were using, how they were using different things, who they inject, you know, but we don't necessarily know how to like incorporate all of that information into the model. And so I think trying to make it simple things like, you know, how many injecting partners do you have? What's the likelihood that you're going to share a syringe or something like that? And parameterizing that, I think, is like where we've kind of started in trying to figure out like to build these more complex models. Because you can just like, it's like a never ending thing. Like I can always make it infinitely more complex, but I'm not sure I'll like gain more insight.
We have one question in the chat.
Yep.
How much are you able to use different data sources to study mobility in kids? And if you see mobile phone data for kids increasing over time as more kids are using phones?
For society, I hope more kids are not using phones. So yes, the movement of children is like a huge gap in terms of these data sets that you're often using that you don't collect, particularly like really little kids. So when we've tried to compare it with like, and in a number of like surveys that we've done, we've also asked like, who are you traveling with? Are you traveling with anyone else in your family? And if so, what are the ages of those individuals and things? We often see that like really little kids don't really travel on their own very far. So if you're capturing the movement of like the adult population, you're likely overestimating but still capturing some of the movement of children. But then often, we've also looked at some of these data with like school terms and things like that when you would expect more like child independent movement and things. And they broadly sort of like align together, but we don't really know how the scalar factor of that and how universal that is. We've done some work in Zambia of how you could adjust the data to better capture the movement of children, and in Kenya, but we haven't necessarily, I'm not sure how generalizable that is. Like, I'm not sure that would be like relevant to do for like the US population, for example. But we try to piggyback in some surveys and ask like, are you traveling with kids effectively when you're taking all these different trips?
The examples you gave, especially the second part, were about taking data
like try to measure like that mobility must have decreased because they saw a dip in cases.
Yeah, something along those lines. Is there any ability to do that at this point?
There is some ability. I mean, I think that like some of the examples that have shown that are during COVID, but effectively, like if you can't tell that like people stayed at home, like almost any data set but the temperature outside, I think could tell you that people started staying at home when you saw that increase in cases. There is some ability to do that. So some of the work that I'm not presenting is trying to sort of like not changes in behavior, but overall injecting behavior and looking at HCV seroprevalence and trying to look at like try to predict that through the mobility, through the different like behavioral variables, which can work. It's just very, very hard to do. So I think that like it's much more common and much easier to just try to take it as like an input than try to back it out. I think certain pathogens in certain settings, it's easier to do that. Like I think the most canonical example is the measles work where they're able to try to estimate like what the like a coupling rate is between things. But you know, that's something that you'll have like high reporting, real like dead times where you're not actually seeing transmission, and then like very large peaks to be able to do it. A lot of things that kind of like hum around, it's often a little bit too messy, I think, to be able to do that directly. Not bad ones. No. No, we've just kind of been bothered for many, many years where people ask us, like, I just need to use something. I'm working on something completely unrelated to any of these things. I just need to be able to say that these places, no one's likely to go between those. Like, what do I just use in, like, a most basic instance? So I feel like a lot of times people are doing stuff, you know, like they're working on, like, phylogenetics of, like, I don't know, some random-ass virus or something. And they just want to be able to say, like, these things are far or, like, not likely to go. Because, like, reviewer 3 was, like, real annoying. And so I feel like there's a lot of people who have that application where they just want something that has been like somewhat validated and at least they have a sense of like the uncertainty of those estimates to use in that, because that's not like the main thing they're focusing on. So that's like the weird niche demographic that I think we're trying to target. But yeah. I want to help you all for review. See, right here, we have a first customer, man, right here, who wants a reviewer 3 was annoyed that Euclidean distance did not work very well, and so that's who we're going for. Yeah. There's a weirdly large market, particularly if you go to anyone who's made a map as a figure 1 and then never used the spatial information ever for the rest of their paper. We have an R package for you. Yeah. Yeah. No.
Okay, I think this is a good point.
Excellent.
To wrap things up.
Right.
Thank you
Thanks so much.
much.